بدنا نبدأ الاكتيفيتي اليوم بعلم من أعلام جراحة القلب بالعالم، مش بس بالشرق الأوسط. الدكتور رائد النجار، وهو يعني روبوتك اند ادفانس. المحاضره يعني بدها تكون ذا فيوتشر از ناو روبوتك اند ادفانس تكنولوجي ان ذا كاردياك انترفنشن. طبعا الدكتور رائد يعني غني عن التعريف، اللي هو بروفيسور اند ميديكال دايركتور اند كارديوثوراتيك سيرجن، دايركتور اوف روبوتيك كاردياك سيرجري ب هنري فورد هيلث سنتر. فأهلا وسهلا دكتور رائد، وتفضل.
صباح الخير وأهلا وسهلا بالجميع. Thank you so much, Dr. Hussein and Dr. Mahmoud for and everybody. Um, I feel I'm honored to be there with you guys. Uh, Usually when I do presentations, it's easy for me, but today I feel I'm intimidated and emotional because intimidated because I know I'm sitting in front of many people. Some of them are my mentors. They taught me a lot in my medical school when I was بالجامعة الأردنية and in my residency in Jordan before I came to the States. And emotional because I would love to be there with you guys, but for a lot of the current issues happening in the region, I couldn't get through my flight. So I'm so sorry and I apologize. Inshallah, next year I will be there in person and meet you guys, everyone. So, talking about the topic, I know this is a topic which is very close to my heart. This is my passion about robotics and minimal invasive cardiac surgery. And actually, not only about cardiac surgery, it's also any technologies in the cardiac intervention, whether structural heart, cardiovascular medicine, and cardiac surgery. Um, I worked at Henry Ford for the last 10 years, and I'm the director for also the robotic program in the whole healthcare system in Henry Ford. So these are some of my disclosures. I work with many companies, mainly the robotics. And as I said, one other disclosure I have is like I'm extremely early adapter for the technology, specifically when it comes to robotics. So I'm biased about it, and it's going to be hard to discuss that with me because I believe robotics is the future. Um, I will start with this and probably I will end with it. Robotics is no longer, they're no longer the future. It is now. The precision is now, transformation is now, and robotic is not an evolution. It's actually a revolution that I think need to expand and go everywhere, not only in the US. Um, uh, at the end, I think I will leave some time for discussion and for questions. My main interest is robotic assisted cardiac surgery, robotic catheter navigation system, AI, advanced imaging technologies, hybrid operating rooms, and telerobotics and remote procedures. I have a lot of interest and involvement with the industry in the US. So these are some of my main interests, and I'll be more happy to discuss any of these in the future or with anybody. I can speak about this for 8 hours, not only for 30 minutes. Um, what can we do with the robot as a cardiac surgeons? And I know the audience a lot mainly is cardiologists, but it's good to know what can we do with this. Basically, in my opinion, any cardiac surgery procedure that we can do through Serenity can be done with the robot. But if I want to summarize the most common or the what we are trying to get into, mainly the mitral valve repair, replacement, tricuspid valve, coronary revascularization. A lot of the centers they do robotic mid caps, which we talk about LITA to LAD. There are very few centers that they're doing total endoscopic coronary bypass or TCAP. I think the future is coming. I know there's a lot in the pipeline in the industry that we can actually do that in terms of instrumentation and advanced technology. AFib ablation and left atrial appendage ligation, endocardiac tumors, ASDs, left ventricular leads implantation, and recently even cardiac transplantation, heart transplantation has been done with the robot. Um, This is my passion about, I think, I know as a cardiac surgeon, it's hard to say that sternotomy is the main thing we do, and it is what we do for years and years and years. I hope, well, actually, my mission is like one time in my lifetime that I will not do sternotomies at all, and it will be completely gone, and do all my procedures through a robotic assisted approach. So. The robotic approach has different, there are different differences between different surgeons. We don't have the full standard, but basically, it is an approach that we do through small ports on the right side of the chest, most probably. When you do TCAPs, usually it's on the left side. It consists of three or four ports, about 8 to 10 millimeters. The working port also can varies between like a smaller port of 8 millimeters to about up to 3 or 4 centimeter. And through these ports, you can do the full procedure. The key features for the robot is that uh, the main thing is the high definition 3D visualization with the camera. That's really the most important thing. In addition to that, the extremely enhanced dexterity via wristed instruments where you can do 360 degrees with your instrumentation, and the tremor filtration for micro precision and having less trauma to the tissue. There is a lot of talk, I don't think I will go in details about it between what will be the difference between minimally invasive versus robotic approach. And I know many, many surgeons do minimally invasive, and it's a great approach, and it's much, much better than sternotomy. But I personally biased for the robotic approach because I think as I said, the high definition imaging camera and the articulated micro instrumentation with the robot make it much easier and more precise to do this. For example, I can tell you, I repair mitral valve with the robot more than what I used to do with mini sternotomy or even with sternotomy because the visualization can allow me to do that. Um, some of the benefits that we talk about with robotics, the smaller incision, which subsequently led to reduced surgical trauma, less blood loss, shorter hospital stay, faster return to daily activity and recovery. And in a lot of new studies showing that it has either not only equivalent, but in many cases superior outcomes to conventional sterotomy in experienced hand and experienced centers. Challenges that we have, it's the main challenge. One of the challenges is the complex anesthesia preparation, double lumen intubation, echocardiogram guided insertion of catheter and cannulas, of course, to go on bypass the femoral arteries, peripheral cannulation, the sizes of the arteries, and the status of the artery is important. What will be the technique of cardiopulmonary bypass and cross clamping and the myocardial protection technique? These are the challenges, and if you cannot master those, then the robot can be dangerous. The keys to success for those, we have four keys. The main one is training and training and training. It takes significant amount of training to be there, and you have to have a highly specialized team from the anesthesia, perfusionist, bedside assistant, OR staff, and nurses. Echocardiogram is and reading echocardiogram is crucial, and the patient selection. And I would say the patient selection, I know some of the centers were very selective with their cases. In my opinion, that's unfair for the patient. I think uh, any single patient should have the opportunity to go through the robot if we can. There are very small amount of contraindication, but most of them probably, in my opinion, we should offer it for most of the surgeons. I'll talk a little bit about mitral surgery because it is the most common robotic cardiac procedure that we do worldwide, and basically mitral valve repair. Again, we talk about the benefits: smaller incision, operative stress is less, shorter length of stay, improved cosmesis, a quick return to a preoperative level of functional activity. And there are a lot of studies that show that it has decreased amount of blood transfusion requirements. A little bit of history. Carpentier in 1998 was the first to do that. It was with the early prototype of Da Vinci system. Chitwood in the US in 2000 was the first to do robotic mitral valve repair. And 2002 was the first time the FDA approved the Da Vinci system as a a device to be used for robotic mitral valve surgery. And still, Da Vinci is the only system. However, I think there are more and more systems coming, hopefully in the next few years, and then we'll have more than one robotic platform. A lot of people talk about haptic feedback, how, how can the robot be the same equivalent to when you can actually do that with your hands? Is the haptic feedback a problem? Absolutely not. There are many things about ocular tactility, finger tactility, and strain stress sensors to the instruments that you can actually use to have actually accurate feelings and tactile feelings with your hands to be able to do the procedure as accurate, as efficient, as safe as open sternotomy. Um, Quick, one of the early studies by Mihailovich from Cleveland Clinic, where he actually did a study from 2006 to 2009 in 261 robotic mitral valve repairs. And this was compared to sternotomy or mini sternotomy. It showed no differences in mortalities, similar complication on the neuro and renal, and actually the robotic uh, patients have less atrial fibrillation, less pleural effusions, and shorter hospital stay with the median stay of 4.2 days. Um, why till now it didn't have a lot of adaptation in not only in the US, even in the worldwide, is because of concern about complexity of the procedure, cost, and quality and safety. And to be honest with you, I think also the training and having a complex team that can do these procedures. Uh, I'll show you a couple of examples because I think theory we can talk about it as much as we can, but at the end of the day, I think evidence by cases are usually more revealing. So this is actually my first ever robotic mitral valve repair, and I continue to put it in. Even I think I was very clumsy in the procedure, but it shows that how this is really rewarding for the patient. So this is a 50 years old patient who was very healthy. He has shortness of breath. He has murmur for 3 years, very active, kind of healthy patient. He has a family history of mitral valve prolapse. This is his echocardiogram, which show mitral valve prolapse, P2 prolapse with severe regurgitation. So this patient, another echocardiogram image, and this is also another image, definitely showing that he has significant echocardiogram, significant mitral valve regurgitation. This is his 3D echocardiogram. And this is the procedure. I'll put like, I think it's a couple of minutes just to show. This is, I think, 1.5 the speed, just to go through the process, opening the left atrial free border of the left atrium to gain access to the mitral valve. You can see the visualization. This is P2 resection, and then putting few stitches. This is really where you can see you can move around with the needles any direction. Just to talk a little bit. This is a partial ring. This is the only time I did partial ring because it was my first procedure and I was trying to save some time. I usually do complete ring. I'm not a believer in the partial rings. I don't think they are good. However, I know that many surgeons they do it, and I respect that. Everyone has his own techniques of doing the partial versus complete ring, but I'm a firm believer of the complete ring annuloplasty for the mitral valve repair. So this was repaired, and patient has been doing fine. He went home actually both of day three. That was, I think, 3 years ago. Case number two that I want to discuss, this is not only for simple cases, this can be done even for redo cases or more complex cases. This is a 77-year-old lady who had severe mitral valve regurgitation. She had aortic valve replacement surgically in 2008. And because of that, when the first time she came forward with a severe MR, everybody thought that a redo surgery might be a little bit of high risk. So they tried a mitral clip, but it failed and it didn't work. Otherwise, she was hypertensive and have some pulmonary hypertension. This is echocardiogram, which show the clip that has been placed before, and it's actually completely detached from the posterior leaflet and with significant mitral valve regurgitation. This is another view for that. So, and the third D images. This is hair video, and even as you can see with patients who have adhesions, still you can actually release. I'm still not even on pump. I'm actually dissecting the pericardium from the heart, and then we went on bypass, and you can see this is the aorta here, and we have cardioplegia and the heart got arrested, and now we will move to the free border of left atrium to gain access to the mitral valve. You can see even with the redo with adhesions, you can see very well. This is a huge, great visualization. This is the clip that has failed in this patient. And this valve was, there was no way to repair this valve because it's completely destroyed. So end up with replacing the valve. So even mitral valve replacement, people think that it's kind of challenging with the robot. It's not. This is a mitris valve, which I use, which is a tissue valve. I think made of Brazili these days, one of my favorites. And this is the mitral valve replaced with the robot. And after testing the valve, um, which should complete nice position of the valve with no leakage. And this patient went home post up day 3. This is her post-operative echocardiogram, which showed a nice biprosthetic valve for her. So this is a little bit about mitral valve. I know I have 15 minutes, so I'm on the 15-minute mark. The second topic was about hybrid revascularization or bypass. I think everybody knows, and we all, it's well established the benefit of LITA to LAD. This is something I believe it's the gonna be the continue to the goal to be the gold standard. So the hybrid revascularization, which means trying to do a LITA to LAD with the robot and then stenting of the other coronaries. Benefits for that, I think many studies at this point and more coming. I think I will publish my series of 500 cases hopefully by the end of this year. A good long-term outcome, overall cost benefit over traditional CABG due to the shorter length of stay, less postoperative pain and atrial fibrillation, less blood transfusion, less OR time, less ventilatory support, fewer strokes, and decrease in the ICU stay. Uh, and I know this is a topic that still not well perceived by some cardiac surgeons and some cardiologists. My disclaimer here is this is not intended to compete with the traditional sternotomy. I can tell you that many patients who have multi-vessel coronary disease, if you can do complete arterial revascularization for those people, for those patients, it is the standard of care and that nothing will compete that. But this provide a gold standard alternative to multi-vessel stenting. Patients who doesn't want to have their chest open or cracked and instead of have full stenting for multi-vessel coronary disease, I think LITA to LAD with stenting of the other blockages is actually a much better and superior to the just multi-vessel stenting. And this is also offer options for patients who are frail or high-risk patients who whether they are high risk for surgery or for PCI. Main indicators, patients with severe ostial LAD, long LAD lesions that stents might not be the best option for those. CTOs, patient with severe coronary disease and advanced age or comorbidities, complex disease involving the LAD and diagonal arteries. Contraindication, I can tell you for in my dictionary, there are very minimal or very few contraindication, except if you have extensive lung surgery or the internal artery, thoracic arteries are not usable for any reason. But adhesions or previous pleural surgery, still you can actually do that. Obesity, significant heart enlargement, chest wall deformities, diffuse coronary disease, or intramyocardial coronary arteries, pathways, or severe lung disease are relative contraindication. I won't recommend somebody starting to doing those to do those cases, but ultimately you can do those patients for you can offer them robotic bypass without any problem. Hybrid revascularization has been, there's a lot of talk about it. This is one of the early studies in 2014. It was about 200 patients comparing hybrid versus multi-coronary artery disease bypass, and it shows no differences in 12 months with patients were equivalent in terms of MACE. There was no significant difference between both groups. This also was confirmed by 5-year clinical outcome. All-cause mortality, myocardial infarction, coronary reintervention, stroke, and major adverse effects were almost the same. Same all-cause mortality at 5 years for both groups. I'll show you a few examples, and that's what I said, to me, I feel like this is more important. So this is a 70 years old patient who came with chest pain. He had liver cirrhosis. So he has multivessel coronary disease. So it was going to be a significantly high risk for him to go on bypass with his liver cirrhosis. So this patient was taken for robotic bypass. Robotic LITA to LED, it's 3 ports, as you can see. Each one of them 8 mm incision, and then eventually, depending on what you do, you want to do the anastomosis with the robot. Although each one of us, I won't put a video here because it's not the standard yet, and we don't have like the full instrument where we can do it with that. I show like we can do it with a small incision below the left nipple, and then you can do the anastomosis directly through that. Uh, this is oh, I don't know why there is this noise, but this is trying to take the LITA to LED, harvesting the LITA for some reason. There's a noise there, so I don't know. I'll skip it. But this is the first patient. He has multi-physical coronary disease, significant disease to the LAD and the CIRC, and I think the RCA. So another view of his cardiac catheterization. Um, this is his LITA to LED. So usually when I do those, I do the robotic bypass first, and I waited for 2 weeks, and then I ask the cardiologist to come back and do the stenting later on. Um, I know there are some different practices where they do it combined at the same time. I feel like it's still, I'm not a favor of that. I do believe like I want to do the Lima to get better and then come back for the stenting. So this was his LITA, which was beautiful and open. And then he was taken back in 2 weeks, and his circ was stented, and his other blockages were stented. And this was the final outcome. I have been doing CT coronaries after 1 year for all my robotic bypass to just check on the patency. So you can see a beautiful LITA to LED after 1 year from the bypass. Case number two, this is a 73-year-old male patient who also have multivessel coronary disease. Actually, this patient came with STEMI with 90% circ, and he was stented for the circ, and at that time they found his LAD was CTO. Uh, Patient came for surgery. His LAD was completely blocked, and I have to do endarterectomy, which is another topic we can talk about it. I know there is a lot of debate about that. I do a lot of endarterectomies, and I do believe their outcome's great if it's done in an experienced hand in a good way. I think there's a huge role for endarterectomy in the cardiac surgery. This is his actual LAD on the table, completely taken out. And then this was done with a robot. And this is his 1 year follow-up CT coronary, which show patent LITA to LAD. So even this is a proof that endarterectomy, which I know there's a lot of debate about endarterectomies and patency rate after endarterectomies with intimal hyperplasia. This is a proof that 1 year follow-up with the robot, that Lima was patent to the LAD. Case number three, this is a 43-year-old patient who had multivessel coronary disease, and this patient was extremely against sternotomy. He was like, he was like, no way, nobody can crack my chest open. So instead of having him with multi-vessel stenting, we got him LITA to LED and stenting of the other blockages. This is his pre-op cath, which show uh, PD lesion and then LAD disease with the DAG disease. Patient was taken for robotic bypass, and this is his LITA to LAD. Beautiful, actually perfusing the whole LAD territory. Then he had stenting of his right and his diag, and eventually the full outcome was he has total revascularization. This is his 1 year follow-up with a CT scan showing patent LITA to LAD. Another lady, I'm just giving some example of different category. This was an 87-year-old male patient, unstable angina, came in with coronary disease, has multiple PCI from before. His left main was 80%, significantly calcified coronaries, and his RCA was chronically occluded. And at the same time, the patient has severe aortic valve stenosis. His cardiologist called me to the cath lab and he said, "I don't think this is really high risk to do any stenting with this." This is his cardiac cath, and this was an 87 years old, and so this is his coronaries, extremely calcified, significant distal left main. I know it can be done with PCI, but the heart team approach that we took for this patient, I took him for LITA to LED, and this is his robotic bypass after 2 weeks, patent LITA to LED. Then he was taken back, and the circ was stented to the left main because you have a protected LITA to LED, and you don't even have to put him on impella or any support for that. So he had the stent, and it was with a great outcome eventually. This is the catheterization, and then eventually within I think a month we took him back, and he had a TAVR for his severe aortic valve stenosis. So this is one of the cases where, although he was 87 years old, he eventually had kind of complete revascularization and treatment of his aortic valve stenosis. This is a 66-year-old lady, complete vascular bath. She had significant peripheral vascular disease and was found to have significant coronary disease, and she was not candidate for full sternotomy. She was really very malnourished, significantly non-compliant. And this patient, before I took her for robotic bypass, I usually do CTA of the chest. Her left subclavian artery was significantly stenosed, so this need to be taken care of. And this is where I can tell you the multi-specialty approach. This has a significant Brock's subclavian stenosis, so we did a stenting of that before even taking the patient to do a robotic bypass. This is her LITA, and then just to show after, having the stent done, the great flow that you have with the LITA, and then eventually she had the LITA to LED, and that's all what she needed because she was not candidate for anything else. And this was anastomosis through the small incision. Patient went home, and I think uh, 3 days. Next steps, what should we do with this? I think the hybrid approach will continue to continue to evolve more and more, and I think it's gonna be like in the future this will be a leading standard for coronary artery disease. Beta harvesting, which is I already do, and many of the centers in the US right now trying to do not only the left internal thoracic artery but right internal thoracic artery, give the patient two arterial grafts mainly to the LAD and maybe a high RAMS or high OM, and stent the others. Of course, we need the industry support for this significantly. So I go back to the hybrid revascularization. I think it's alternative to multi-cabbage procedure. It's also alternative to multi-visual PCI. So robotic LITA harvest with minimal invasive LITA to LAD, it's alternative to both, and specifically for multi-visual PCI with LAD stenting, specifically in younger patients. TCAB, I know this is not probably the topic, but I will say that this is the total endoscopic coronary artery bypass. It's still in very primitive because we don't have a lot of support from the industry. We have trials. Each one of us is doing his own way of doing it. There is no standard, although I can tell you confidentially there are some instrument and stabilizers that we will need, and they're going to be available for in the next probably year or two. So I think the option of TCAP will be even more and more popular, hopefully soon, and for that. This is probably not related, but since I have a couple of minutes, this is a patient who was coming for CT, and we found that the patient has right atrial mass, and this patient taken for robotic patient this was an atrial myxoma on the right side. Again, this was also done with a robot. Here exposing, showing more images to show how much this the visualization can be great. Opening the pericardium, aorta, and exposing the right atrium, snaring both the superior vena cava and inferior vena cava to isolate the right atrium so we can actually open it and excise the myxoma. So I have umbilical tapes around both the superior vena cava and inferior vena cava, and having the antegrade to cardioplegia to arrest the heart. Heart get arrested, and opening the right atrium. Basically, this is the myxoma, which is it's rare to have it in the right atrium. It's usually more or less on the left atrium, but this was right atrial myxoma, which was completely excised um, with a margins from the septum. And again, this patient went home actually both of day two. Primary repair, and that's it. So as I said, I brought that earlier. It's no longer the future; it's now, and I think the robotics will have extremely more important value in our daily cardiac surgery and interventional cardiology. So as I said, in robotic and advanced cardiac intervention, it's already arrived. It's happening right now and right here. So our challenge is not whether the technology exists, but how boldly we choose to adopt it. Robotics and advanced technologies empower us to deliver safer, more precise, and more compassionate care. For our patient, this means hope. For our team, this means empowerment. And for our institution, this means leadership. And I leave you with questions. You can scan this barcode and you can contact me, my emails and my phones if you have any question, if anybody is interested. The last thing I will say before I open it for a question is like, this is one of the passion. I hope that eventually, I know we're still having a lot to do in our region, in Jordan, and I think we should. I would like to see the day where we actually can bring robots and all these advanced technology to our region and help our patient with all these newer and safer technologies. Thank you.
Uh, Thank you, Dr. Raed, for this productive information about the robotic surgery. I want, it is the future of the cardiac surgery, really, and with combination with the cardiologist for hybrid procedures. My question, you do the robotic surgery mainly for the for the cabbage with on pump or off pump?
Off pump. These are
Off,
all off pump.
mainly
These are
off
for,
pump.
yeah.
Mainly
Now, now when I'm going to do, I did it. Sometimes I do. If I'm doing it with a small incision, I just do it off pump. If I'm going on pump, if I'm doing more than what we call TCAB, you have to go on pump.
Uh,
And I think in the future, once we have a stabilizer coming, I think I'm going to do it like actually on pump with cross clamp.
any question from the audience?
Good morning, everybody. Thank you, Doctor, for this interesting and very nice talk. Really, the results are very, very impressive. I'm Dr. Hamid Mada. I practice in Palestine, so robotic surgery is, is not practical in our conditions. So I would ask you about mini invasive. What's the difference between mini invasive cardiac surgery and robotic? Mini invasive is much cheaper and easier to do in Palestine than robotic surgery. That's it. Thank you. Thanks a lot.
Thank
I totally agree, and I know. I mean, if the robot is not available, which is unfortunate, I can tell you definitely minimal invasive is much better than sternotomy. Anything you can do to avoid sternotomy is actually a plus for the patient. But as I said, if you want to go further and further in the science, yes, they are great, and many people, I don't claim that I am a good minimal invasive surgery. But robotics for me, it's what I actually found that it's more accurate and more probably more precise for me. However, minimal invasive surgery is actually a huge thing to do, and I think if that cheaper and that is available, it is probably something we have to do. Having said that, I think the future, the robots, when we have more and more, I'm not saying that this can happen today, but I see this in the next 5 to 10 years. I think with the availability of more robots and competition goes down, I think the robotic cost will be probably almost equal to the minimally invasive, but it's gonna take more years to come. And I'm talking about the US. I don't know how the Middle East and how the other regions. I mean, I see we're having some discussions. There is a lot of adoption of robots in Saudi and in the Gulf region, in India and China. I hope that we will see this more and more in our nearest countries in Jordan and Palestine, inshallah.
any question. Okay.
Thank you for a great talk. My question is, what percentage of open heart surgeries done in the US now that use robot, and what kind of a training a surgeon needs to start doing it?
That's a great question. I think I don't have the exact number in the last 2 years, but before I think it was about 5 to 8%. And I think the numbers are growing. The key for this is like the industry was not very supportive of this because actually FDA has no approval for this. This was done basically on individual basis. So I'm interested in it. I go for training. It's my responsibility and I do it. And that's it. Now, actually, finally, this year we have a cardiac training track at this point by Intuitive, which is the main company that produced that. Actually, myself, I'm one of 5 centers in the US where we're gonna actually train people. The training is going to be very comprehensive. So the training, it's basically we have to look at the site to make sure that, for example, you have early access, you have a continuous access to the robot at least once a week. You have a team that is dedicated for the procedures. You have certain numbers. So, for example, if to do robotic mitrals, you have to have at least 40 to 50 mitral valve surgeries in the last 2 years. For bypasses, I think you have to have at least 100 bypasses a year. So not everybody will be a candidate for that. Then we'll take them for cadaver training for, I think, 3, 4 days. And then they come for observation for a week. And then we go back and do more training. And then eventually you proctor them for 5 cases. And then virtual proctoring for the first 20 cases. So it's an extensive process that we actually started, and it's going to be published by the STS this year. So it is kind of an official for a pathway for robotic mitral training or robotic bypass training.
Any question?
Thank you, Dr. Thank you, Dr. Najjar. Surely the cost is the main factor in this training. And you know, without a robotic machine, the area it's really difficult. Could you give us approximately what's the cost of the robotic nowadays and the training cost, how it's cost?
So, like if I not very, precise numbers. So I know, like, for example, the XI robot is, I think in the US, it's $1.5 million. And if you actually get it in the US, if you do, I don't know the number, the latest number, if you do 15 robotic cases, you will actually reimburse with the price of 1.5 million. Now, in training, I think to train a surgeon and a team, it will cost about 60 to $100,000. Now, if you're gonna move to the DV5, it's going to be for, which is again the cost, the new robot, which is have more advantages and more technology, it's going to be 4.5 millions. And I'm talking about the price in the US. I know the prices when with the local distributors in different countries is different. For example, I know that I'm training some of the surgeons in Saudi Arabia. The price of the robot is almost tripled, and that's what the local distributor is doing. So yes, I know the challenges for this is the prices. The challenge for this is the cost. However, actually, if you talk about the cost in the US, the cost of robotic surgery comes with the length of stay. The length of stay is more. The length of stay in the US per day is really extremely high. The OR time is also costly. So when you actually calculate the OR time and the blood transfusion and the complications and the length of stay, it's almost equivalent. So that's what actually, for example, Henry Ford I was able to show them by numbers that robotics will actually probably equal, and maybe in the future will save them money. So they took it. And of course, when you become the robotic program, you will have more referrals. So like I get more referral than any other institution in Michigan because we do robotics. So if you look at it at a future, eventually actually you're making money. But that's in the US. In the rest of the world, I think there is more and more challenges, and there is more to do about the cost for sure.
Any other question? I have a comment and suggestion, mainly for the fifth case, which you produce, the myxoma, which is done by robotic. And we have, from our experience, our colleague, he's going with minimally invasive for this procedure, and unlikely, or for his bad luck, because it is fragile, it's disseminating to the coronary artery and to the brain, and we pass the patient. So I have a suggestion, because you are pioneer in this field. Why not to use a basket, looks like in the general surgery for gallbladder stones, to contain the stones before are going to dissect and remove the myxoma by robotic or minimally invasive surgery. Thank you.
I think that's a very valid point, and yes, I think manipulating you, so it's very gelatinous, it's easy, fragile, and if you don't handle it very well, yes, if it actually embolize, it's a disaster. We did actually a few of those with angiovac, specifically patients who are not surgical candidate. We actually did that with angiovac. The problem is like, how can you make sure it's completely resected? And the recurrence rate for those. I don't have, because these are very rare. I do probably 4 or 5 a year, not so often. So it's hard to do a study on those. But I think your point is very valid. Can we find a different technology to come and take it with a basket or something? Absolutely. But I think more to come to think about it.
Thank you very much. Any question? Thank you, Dr. Raed, very much about this productive presentation, and we are thankful, and we hope to see you maybe next year to mainly for the young surgeon to take a good points and going for this field, because it's the future of the cardiac surgery. Thank you very much.
Absolutely, and I was honored to be there, and yeah, I'll be more than happy, hopefully next year to be there. And then anybody is interested in talking more about this or interested to do any of this, I'll be more than happy to help at all capacities I have. So,
Thank you.